Thank you very much for a kind introduction, Dr. Solomon, Dr. Mbabian, Hamza. I'm Indian, you can tell from my face and my name, so I really feel welcome here in Egypt, and maybe that's why I keep coming here again and again. So it's a distinct privilege and honor to be here and participating in the Retina Academy. What made me think about how to deal with complex situations is this 30-year-old woman who was 27 weeks pregnant, and she had been diagnosed to have fetal anomaly, which being an orbital growth on prenatal ultrasound. And she had had an MRI and came for an opinion. I don't know if you can see that in this scan, but here is the face of the baby, here are the lips, this is the chin, sagittal view, here's the eyeball, here's the lens, and the optic nerve is from here to here, stretched by an orbital cyst. On an axial view, you can see again, this is the normal eye, and this is the other one. Okay, you can appreciate the complexity. And then I told her what I was supposed to tell, and then she asked me this, how do I know what I said was right for her and her baby? And honestly, there was nothing I could say with confidence that what I was saying was right, because we really don't know how to manage such a case. So that made me think, and I said, well, it shouldn't be very difficult. Being an oncologist, I do deal with complex things, rare cases, serious conditions, for which there are no guidelines, there are no consensus, many opinions, but no evidence. And that's why everyone will give their own opinion. And everything we do has consequences. We're using chemotherapy, radiation, talking about enucleation, talking about deaths. So everything we decide has huge consequences. So that really made me think and come up with a strategy and how to deal with all this. So what's the strategy? I said, well, it's just like walking in the garden. And you heard about hobbies, travel, and photography, and cooking. So this is walking in the garden. I said, like, go and take a walk. Well, which garden? I said, well, Azhar Garden in Cairo. Huh? So I've not been there, but I took a picture from the internet. I'm told it's a very beautiful garden. So when you go in the garden, you say, first, well, look at the tree. Context is the key here, for example. So here's a patient with small choroidal melanoma. Whether he or she is 40-year-old or 90-year-old, it matters, because the risk of dying from melanoma, from small melanoma, is very low. And in older person who is 90 years old, chances of her dying from something else is 6 times more than that from melanoma. So don't scare this old lady with a small melanoma that she's going to die from it. She's not going to die from it. She'll die of something else. Okay? So context matters. Maybe you can observe this case. You don't have to do anything. But in a 40-year-old, you think differently. So the context matters. It's the same disease, same findings, but the context really matters. And it's driven by data. It's not just my opinion. I'm telling she's going to die of something else, not of this melanoma. Moving on to second, but examine the branches, assess the components. Well, here we have a African American who has choroidal melanoma. Look at the fundus picture, look at the B scan, look at the A scan. This is classic. But we know African Americans do not get melanoma, or at least 150 times less common than white people. So I will certainly do a biopsy here. So that it matters what are the other components of the patient. And then zoom out of the forest to see what else is happening. So here's a patient with with radiation retinopathy. You can see treated melanoma, you can see cortical spots, hemorrhage, you can see CME. But you say, well, we don't know how to treat radiation retinopathy, but it resembles diabetic retinopathy. So you can use one of those 8 things. You heard about anti-VEGF agents, you can also use steroids. And in fact, we have a big trial coming up through DRCR network, checking out those things for sure. Anti-VEGF and steroids and observation group for radiation retinopathy. This will start early next year. Protocol AL, okay, this coming. So we are taking this from diabetic retinopathy and adapting to radiation retinopathy. And don't get lost in the details. Patients have complex histories. They have had so many things done to them by the time they come to us. So here's a lady with a metastatic breast cancer, known history of metastasis, known history of breast cancer. And she says, my vision is blurry in one eye. When you look at it, you say, I don't see a mass here. I just see subretinal fluid in the macula, looks like CSR. But we always think of metastasis, correct? Then you say, you know what? She's getting high dose steroids with the chemotherapy. Many times with chemotherapy infusion, they're getting steroids. This is CSR. So the moment you capture that history from this big history that she has of this drug and that drug, say, I'm okay with that. I found high steroids and CSR, that's it. There's no mass, it's no med. It's very easy. Within a few minutes, you can come to a diagnosis. If you don't, you really need to know what to pay attention and what not to. Then, and obviously, you can't learn everything in your fellowship of 1 year, 2 years, or even 3 years. You have to keep learning, and you really need to have a network of people that you work with. So earlier today, we had a good session in oncology, discussing all the cases seen here in the Cairo University, discussing different options, different opinions, how to think about it, how to treat them. So this is my small network of my fellows who have trained, and they ask me. I don't ask other people anymore because I've become a little senior, but when you're starting out, you ask others, and as you get older, the trainee-trainer scenario that we talked about earlier. And the last one, he said, you really have to slow down and think because these are complex cases. And I don't know how much you know about thinking process. People have won Nobel Prize describing thinking processes. We have type 1, which is like the fast, intuitive, unconscious. And every time when we are learning as a resident, they're teaching us to think very fast and quickly make diagnosis of CNV and go and give an injection fast. Okay? Don't think. Look at the OCD and give an injection. That's what we're learning all the time. But really, it can induce biases and take you the wrong way. What you really need, at least in oncology, is this type 2 kind of thinking, which is slow, deliberate, and conscious. So in 15 minutes of consultation, I see up to 40 patients a day, which doesn't take me more than 15 minutes per patient. And once in a while, I have a patient, I said, go home, I'm going to think about your case and call me in 2 weeks and tell you an answer. Because I can't figure out in 15 minutes what's going on. And it's okay. You can tell them it's complex. I need to go over many, many things. And when I have in a week or two, when I have some time, I'll come back and call you. So I do that, not all the time, but few cases like that per year. So you really need to sit back. So I would say type 1 is this fast kind of things. I'm not so sure that's very good, but type 2 really is what we need in oncology. So with that, we say everybody can access data, and many people through the internet can find information. When they come to you, they're looking for some knowledge. And what I try to give you was some wisdom. And wisdom comes with time. So everybody here, sitting here, have gray hair, okay? You cannot learn this in fellowship. It will take many years to get to wisdom, and this is a summary of how to deal or how to dissect out a complex situation. Some of these will help you. Thank you so much for the privilege.